Thank you for the invitation and the introduction. So my talk is on genomic testing in clinical decisions in the context of hormone receptor positive early breast cancer. And these are my disclosures. So why is there a need for genomic tests in the context of adjuvant systemic therapy in early breast cancer? Really, this is to provide guidance in addition to clinical factors to help us to escalate or de-escalate adjuvant systemic therapy. And this is probably particularly relevant for de-escalating chemotherapy. And among the various biological subtypes of breast cancers, we know that HER2 positive and triple negative breast cancers are biologically more aggressive and are generally treated more intensively. So there is a relatively less clinical need here to identify patients to de-escalate systemic therapy. But on the other hand, for hormone receptor positive HER2 negative subtype, this is a much more heterogeneous group. And although in this group, we can use clinical risk factors to identify quite confidently a low risk population who will not require chemotherapy, as well as a high risk population who will benefit from adjuvant chemotherapy, there is a fairly large intermediate clinical risk group here belonging to the gray zone, which represents an area of need where it would be appreciated if there are tests that we can use to help us guide treatment decisions. And this group of intermediate clinical risk patients would broadly fall under those patients with high risk node negative disease or low risk node positive disease. So if we have a genomic test, the expectation of that we get the following clinically relevant information. So we hope to get prognostic information in the form of risk of recurrence, as well as predictive information in terms of likelihood of benefit from adjuvant chemotherapy, as well as likelihood of benefit from extended adjuvant endocrine therapy. So in the past 2 decades or so, multiple genomic tests have been developed for early breast cancers, and the most well-known are Oncotype DX, Memoprint, Endo Predict, Breast Cancer Index, PAM50 base, risk of recurrence score, and so on. And in a recent systematic review of 71 studies that involved more than 500,000 women with early breast cancer patients who had a genomic test that was done, the overwhelming majority, 96%, were tested with Oncotype DX, 3.3% were tested with Memoprint, and 0.2% with Endo Predict. And while this is not really a real-world study to look at the relative utilization of these genomic assays, it probably does more or less reflect the real-world distribution use of these genomic assays. Probably in countries like India and Singapore, it is true that Oncotype DX is probably the one that is most commonly ordered, perhaps followed by Memoprint. So for my talk today, I will focus on these 3 genomic assays that are probably most commonly used in the clinic. So firstly, there are some commonalities between these 3 assays. They are all RNA-based genomic assays, and they all provide information on recurrence and likelihood of benefit to adjuvant chemotherapy. And here I just want to make a high-level comparison between these 3 genomic tests to highlight some similarities and differences. So the Oncotype DX recurrence score is a 21-gene assay that's developed in North America, originally largely based on data from the NSABP series of trials. It provides a quantitative score from 0 to 100 that in turn divides the patients into 3 risk groups: low, intermediate, and high risk. So you will be aware that in the original scoring system, patients were scored as low risk when they had a score range from 0 to 18, intermediate risk if they had score range from 19 to 30, and high risk if the score is more than 30. But in the subsequent prospective TAILOR-X study, these scores were arbitrarily adjusted downwards, such that a low-risk patient is defined as someone with a risk score of 0 to 10, intermediate risk score, someone with a score range from 11 to 25, and high risk from more than 25 onwards. So this does have some implications on the interpretation of the data, as well as the reason why some of the international guidelines were established, which I will discuss a little later on. The Oncotype DX was not developed prospectively with clinical risk factors in mind, although subsequently in the TAILOR-X study, there was an attempt to incorporate clinical risk factors retrospectively. But what is obviously very well known about the Oncotype DX is the 2 prospective trials that have been conducted to confirm its clinical utility, namely the TAILOR-X study for N0 disease and the RxPonder trial for N1 disease. The second genomic assay is the Memoprint, which is a 70-gene assay that is developed by the Europeans, which divide patients into low and high risk. So it does not provide a quantitative score, but the Memoprint was developed prospectively with clinical risk factors such that patients are actually divided into 4 risk groups based on concordance or discordance between clinical risk versus genomic risk. Similar to the Oncotype DX, there is a prospective trial to confirm its clinical utility, which is the MINDEX study that enrolled both N0 and N1 patients. Then the third genomic assay is the Endo Predict, which is a 12-gene assay, also developed by the Europeans, largely based on data from the Austrian Breast Cancer Study Group. It is similar to Print in that it does not provide a quantitative score and divides patients into two risk groups, low and high risk. It was developed prospectively with clinical risk factors, where the incorporation of clinical risk factors into the original EP molecular score refines it into the EP Clin score. But this is the only one among the three genomic assays where there isn't a prospective studies to confirm its clinical utility. So just a word on the impact of age on these genomic assays. So we know that young age is a known biological prognostic risk factor. And in this systematic review of 71 studies that had more than 500,000 women with early breast cancer who had a genomic test, about 5% of patients were those who were diagnosed young, which is defined as age 40 or younger. And when comparing the tumor genomic assay outcome between young versus non-young patients, for Endo Predict and Print, about 2/3 of the young patients had a high-risk tumor compared to just half of the non-young patients. Similarly, for Oncotype DX, which divided the patients into three risk groups, low, intermediate, and high risk, 20% of the young patients returned a high-risk tumor compared to just 15% of non-young patients, although in both the young and the non-young populations, the proportion of intermediate risk patients is about the same at 2/3. So the high-level evidence that have come out from the genomic assays is really from these prospective randomized trials, for which there are now 3 that have been published. So just want to put these trials side by side to highlight some pertinent features. So firstly, the TAILORx study evaluated Oncotype DX, focusing on patients with N0 disease, and it enrolled patients with the full recurrence score range from 0 to 100. The majority of the patients had a tumor that is 1.1 to 5.0 centimeter that could be of any grade, but the study also allowed patients with smaller tumors measuring 0.6 to 1 centimeter if it was a higher grade, grade 2 or 3, but this formed a small minority, less than 10% of the population. There was no pre-planned analysis by age. So this is among the 3 studies, the largest of the 3 that enrolled almost 10,000 patients, of which about 15% were low risk and were given endocrine therapy alone without randomization. The target population here is the intermediate risk population that made up 70% of the population, who were randomized 1:1 to chemoendocrine therapy versus endocrine therapy alone. And the remaining 15% or so were high-risk patients who were given upfront chemoendocrine therapy. The second trial is the RxPonder trial that also evaluated Oncotype DX, but focusing on N1 patients. So just a note that the RxPonder trial did not allow N1 MYC patients. So this restricted enrollment to patients with recurrence score that ranged from 0 to 25, and there was an upfront stratification by menopausal status. The study enrolled 5,000 N1 patients who were randomized to chemoendocrine therapy versus endocrine therapy alone. Then the third trial is the MINDEC trial that evaluated Print, which is focused on both N0 and N1 patients. And the MINDEC trial differed from the RxPonder trial in that it allowed N1 MYC patients who were categorized as N1 disease. The patients were divided into 4 risk groups based on concordance or discordance between clinical versus a genomic risk score, but there was no pre-planned analysis by age, which was similar to TAILORx study. The study enrolled in total 6,700 patients, but about 40% of the patients were concordant low risk, who were given just endocrine therapy alone. About a quarter of the patients were concordant high risk, who were given chemoendocrine therapy alone, chemoendocrine therapy without randomization. So the remaining about a third of the population were the target or the population of interest, who were the 2 discordant risk groups, about 2,100 patients who were randomized to chemoendocrine therapy versus endocrine therapy alone. So all 3 trials had some young patients, about 1/3 in all 3 trials, which was defined as the young being defined as less than age 50 for the TAILORx study and MINDEC study, and defined as premenopausal in the RxPonder trial. So firstly, looking at the data from the TAILORx trial. So over the course of the past few years, there have been 3 major publications from the TAILORx trial, all in the New England Journal of Medicine. The first publication was in 2015, and this first publication was focused on patients with low recurrence score from 0 to 10. 1,600 patients were given upfront endocrine therapy, and at 5 years, invasive disease-free survival was 94% and overall survival 98%, confirming this population to be a low-risk population with excellent prognosis with adjuvant endocrine therapy alone. The second report was in 2018, this time focusing on patients with intermediate recurrence score from 11 to 25. 6,700 patients were randomized to chemoendocrine therapy versus endocrine therapy alone. And at 9 years, there was no difference in the invasive disease-free survival or overall survival with chemotherapy. So the overall conclusion is that there is no benefit from chemotherapy for this intermediate risk group in the intent to treat population. But there was an exploratory analysis looking at the impact of age and recurrence score range. And in this analysis, women who were diagnosed a bit after the age of 50 did not derive any benefit regardless of the recurrence score range. But in women who were diagnosed younger, which is defined as age 50 or younger, those with the lower end of the score range, 11 to 15, did not derive any benefit. Those with a score range that was higher at 16 to 20 had absolute 3.2% gain at 5 years for distant recurrence from addition of chemotherapy. And this gain doubled to 6.5% if the score range was in the highest range of 21 to 25. In 2019, there was an updated report, this time focusing on these younger women with intermediate recurrence score range, but incorporating clinical risk factors, where patients were defined as having high clinical risk if they had a grade 1 tumor larger than 3 centimeter, grade 2 or grade 2 tumor larger than 2 centimeter, or a grade 3 tumor larger than 1 centimeter. So about a quarter of the patients were considered high clinical risk based on this definition. And when the clinical risk was incorporated into this, it was noted that patients who had an intermediate recurrence score range of 16 to 20 and who were at low clinical risk did not derive any benefit, whereas those with score range from 16 to 20 and had a high clinical risk had absolute 6.5% benefit in chemotherapy gain at 9 years. And in patients in the higher score range of 21 to 25, regardless of whether they were low or high clinical risk, the absolute benefit to chemotherapy is in excess of 6 to 8%. So based on these data, Oncotype DX recurrence score was incorporated into the 8th AJCC breast cancer staging. So a patient with N0 tumor with size up to 5 centimeter of any grade that has a recurrence score of 0 to 10 would be staged as a prognostic stage 1A. Similarly, in 2019, ASCO also updated its guidelines on adjuvant systemic therapy recommendations in node-negative, hormone receptor-positive, HER2-negative early breast cancer based on the Oncotype DX recurrence score. So firstly, starting on the high-risk end of the spectrum, for patients with score range from 31 to 100 regardless of age, they are considered high risk and should be considered candidates for chemoendocrine therapy. And this was a strong recommendation based on high-level evidence. On the other end of the spectrum are low-risk patients who can be identified by the recurrence score, by the Oncotype DX recurrence score, which is defined as a score from 0 to 15 in women who were diagnosed at age 50 or younger, or a score from 0 to 25 in women who were diagnosed after age 50. And these women are considered to derive little to no benefit from chemotherapy and can be adequately treated with endocrine therapy alone. And this was also a strong recommendation based on high-level evidence. Then for younger women with intermediate score range of 16 to 25, the recommendation is that they may be offered chemoendocrine therapy, but this was only a moderate recommendation based on intermediate evidence because it is based on subgroup analysis from the TAILORx study. And finally, in patients with recurrent score range from 26 to 30 in women of all age group, the recommendation is that they may be offered chemoendocrine therapy. This was also only a moderate recommendation, and it is acknowledged that the evidence is insufficient because these women would have originally been classified as intermediate risk in the original score definition, but in the TAILORx study, they were just treated as high-risk patients without randomization. So moving on to the second trial, which is the MINDEC trial that evaluated MammaPrint in patients with N0 to N1 disease. So this study had altogether 6,700 patients, although the population of interest that was randomized was only 2,100 patients belonging to two discordant risk groups who were randomized to chemoendocrine therapy versus endocrine therapy alone. Just to note that although this study enrolled both N0 and N1 patients, actually the minority had N1 disease, just about 20%, with the majority of these having only one lymph node involved. So there were two major reports from the MINDEC trial, the first one in 2016. And in this first report, both discordant risk groups did not derive any benefit from chemotherapy. This was then, although in the high clinical, low genomic risk group, there was an absolute difference of 1.5% in 5 years in distant metastases-free survival in favor of chemotherapy, although this difference was not statistically significant. These results were updated in 2021 at 8.7 years median follow-up, and with longer follow-up in the high clinical, low genomic risk group, the 8-year distant metastases-free survival difference between chemo versus no chemo has widened to 2.6% with longer follow-up, although this difference was still not significant. But based on what has been reported in the TAILORx study, an exploratory analysis was performed by age using a threshold of 50. And at 8 years distant metastases-free survival for women who are diagnosed older than 50, there was no benefit to chemotherapy. But in women who are diagnosed younger, at age 50 or younger, there was an absolute gain of 5% with the addition of chemotherapy and a hazard ratio of 0.54 that was statistically significant. While this is an exploratory analysis, these results are concordant with that of the TAILORx study that young patients benefit. So the take-home message from the MINDEX study is that the Memoprint can be used to identify women who are older than 50, who are at high clinical but low genomic risk, who could then potentially be spared chemotherapy. Although based on this exploratory analysis, the utility in younger women is less certain. So moving on to the third trial, which is the RX-bonded trial that evaluated the Oncotype DX in N1 patients. And here, this study enrolled 5,000 patients, all with N1 disease, but restricting the recurrence score to 0 to 25. So the patients were randomized to chemoendocrine therapy versus endocrine therapy alone. And although all these patients had N1 disease, the majority, about 2/3, had just only one lymph node involved. A quarter had 2 lymph nodes involved, and less than 10%, 3 lymph nodes involved. There was upfront stratification by menopausal status and recurrence score range. And in the intent to treat population, there was no difference in the 5-year invasive disease-free survival with the addition of chemotherapy. However, in the pre-planned subgroup analysis by menopausal status, this is for the post-menopausal population with N1 disease recurrence score range from 0 to 25. There was no benefit to chemotherapy at 5 years for invasive disease-free survival, shown in the top panel, or overall survival shown in the bottom panel. But in pre-menopausal patients, you can see that there is actually a difference, and at 5 years, there is a gain of about 5% for invasive disease-free survival and overall survival gain of 1.3% for the premenopausal women with recurrence score 0 to 25 and N1 disease, which was statistically significant. Here, I wish to draw your attention to the survival curves of the post-menopausal patients here. So these are all N1 patients with recurrence score of 0 to 25. And even if they were just treated with adjuvant endocrine therapy alone, the 5-year invasive disease-free survival is excellent at almost 92%, and overall survival is 96%. And this actually is very favorable, even if you compare this to the N0 low recurrence score patients who were enrolled into the TAILORx study, actually just 2 percentage points lower than this very low-risk population, highlighting that the recurrence score can quite effectively identify a very favorable prognosis post-menopausal population, even with N1 disease, with very good outcome just with adjuvant endocrine therapy alone. Then I also want to draw your attention now to the premenopausal patient. If you look at the premenopausal patients in the far right, who have N1 disease, if they were just treated with adjuvant endocrine therapy alone, the risk of recurrence is high and the risk of death is high, but it can be quite effectively mitigated with the use of chemotherapy. And in fact, in the patients who are given chemotherapy, the survival curves are actually matching that of postmenopausal women, underscoring that it is well worth the while to be giving adjuvant chemotherapy to these younger high-risk patients. There is further predefined subgroup analysis for the RX-bonded trial by recurrence score range and the number of positive lymph nodes. And in post-menopausal patients, none of the subgroup of interest benefited, whereas in premenopausal patients, all the subgroups of interest benefited. And there is a sense that in patients who have the higher recurrence score range, the absolute gain is higher. So by now, we have 3 well-powered prospective randomized trials with mature follow-up that is confirming the clinical utility of 2 genomic assays, namely Oncotype DX and Memoprint, to select patients for adjuvant chemotherapy, with each of the 3 trials randomizing several thousand patients with follow-up of up to 9 years. There is a consistent message from all 3 trials that age is an important clinical factor for proper interpretation of the genomic assay. So if we ask the question, can genomic assays identify low-risk patients who can omit chemotherapy, then this question must be answered with age in mind. So for older patients, which is defined as those who are older than age 50 or who are post-menopausal and who have N0 or N1 disease, both Oncotype DX and Endocrine can potentially identify low-risk patients who can omit chemotherapy. For younger patients who have N0 disease, Oncotype DX with a recurrence score of 0 to 15 can identify a very low-risk population who do not require chemotherapy. But for now, Oncotype for N1 patients, in younger patients, Oncotype DX is not informative, and the utility for Endocrine in this subgroup of patients is currently not certain. So just moving on briefly to the third genomic assay, which is Endo Predict. While the Endo Predict does provide information on the likelihood of benefit to adjuvant chemotherapy, its development in this aspect has really fallen far behind the other two genomic assays because of the lack of a randomized trial. But Endo Predict may have a niche utility because there may be potential for this assay to predict a late recurrence. So in this study that was published in 2019, 1,400 women who had completed adjuvant endocrine therapy alone for 5 years and who have had long-term follow-up and had remained distant recurrence-free at 5 years. And the EP-Clin score was applied on these patients. And it was noted that the EP-Clin score can identify patients at low risk for late recurrence at 5 to 15 years, regardless of nodal status. So the question is, can the EP-Clin score help to identify patients who may not require extended adjuvant endocrine therapy? And while there isn't a randomized trial to answer this very important question, there is a prospective observational study that was started in 2019 that enrolled 2,800 early breast cancer patients with N0 to 1 disease who have an EP-Clin low score and who are completing 5 years of adjuvant endocrine therapy with the primary objective of evaluating the 5 to 10 year distant recurrence-free survival in EP-Clin low score patients who did not extend adjuvant endocrine therapy beyond 5 years. So this is a study that is well worth watching because it can provide some data as to whether we could apply this assay in the clinic to tell us who can stop 5 years of adjuvant endocrine therapy and who should extend beyond. So coming back to the original question on genomic testing to guide clinical decisions in terms of adjuvant systemic therapy in hormone receptor positive, HER2 negative early breast cancer, for the issue of selecting patients for adjuvant chemotherapy, we now have high-level evidence for two genomic assays, Oncotype DX and Endocrine, for older patients with N0 and N1 disease and younger patients with N0 disease. Although in younger patients with N1 disease, these genomic assays is still of questionable utility, but obviously not all younger patients with N1 disease will require chemotherapy. So this remains an area of unmet need, and we do look forward to better biomarkers being developed in the future to help in this subgroup of patients. As for the question on selecting patients for extended adjuvant endocrine therapy, there isn't high-level evidence to support any genomic assays, but there is some promise that Endo Predict may perhaps provide some information, and we await higher-level evidence data. So I'll stop here, and thank you for your attention. Happy to take questions.